Hello and good evening to everyone. Welcome to this online session on current research lines in lung cancer testing organized by Lung Cancer Europe, LUCE. So my name is Alfonso Aguaron and I will be moderating today's webinar. Today it is my real pleasure to introduce you to our speaker, Professor Simon Ekman, who is a senior consultant and associate professor in oncology at the Karolinska University Hospital in Stockholm, Sweden. So, Professor Ekman, I would really like to thank you very much for your valuable and precious time today to guide us through such a hot topic on which is the current status of research in lung cancer treatment, which I'm very sure that is in the very interest of our attendees today. So before we get started, I would like to give you a brief overview on the webinar dynamics. So the session will last about an hour. And during the first part, Professor Ekman will provide a comprehensive review of today's current research line in lung cancer, which will last around 40 minutes. And then in the second part, you will have the possibility to ask your questions. So to do so, you have two different ways. If you would like to make your questions live by using your microphone, you just have to press the raise hand icon in the panel of the application you use to join the webinar. And so I will unmute you when it is your turn. If for any reason you prefer to set your questions in writing, you can do so by typing them in the Q&A or in the chat window, and I'll pass them to Professor Ekman at the end of the webinar. So being said that, and without further ado, I really wish you all a very fruitful session. And Professor Ekman, I give you the floor.
Thank you very much for the kind introduction and kind invitation. It's an honor to be able to present on this very hot topic on current research lines in lung cancer. And it's quite a broad perspective. So we will have a lot of things to go through today. So this is my agenda for today. So I will give a short introduction, and then my focus will be in non-small cell lung cancer because we don't have time to go through everything today. And I will talk about activities in early stage, local advanced and metastatic stage of non-small cell lung cancer, and then shortly about screening and some future perspectives. So, as you know, historically, we have treated patients according to one size fits all. So we treat all patients in a similar way. And this is often the case with, for example, chemotherapy. But this has, of course, disadvantages. We know that some patients will not respond and only suffer from the toxicity. So these are the traditional treatments for lung cancer: surgery, radiotherapy, and chemotherapy. And these are still important treatment modalities that we use. But today, today's topics are much focused on the new cornerstones in the treatment of lung cancer: targeted therapy and immune therapy. And this has been enabled by our increased knowledge about tumor biology. So we know much more about, so research during the last decades have given us a lot of knowledge about the signaling pathways that are active in tumor cells, also the tumor microenvironment, the immune system, the blood vessels surrounding the tumor cells. We should also not forget the advances in the molecular techniques and molecular biology. We are now able to sequence and map whole tumor genomes and pinpoint really the changes that are present in tumors. So we, as you know, we don't regard lung cancer as one disease any longer. It's really a multitude of subgroups, each characterized by an oncogenic driver that could be a target for therapy. And I have written here the targets that we can look for and use in treatment in clinical routine: EGFR, ALK, BRAF, ROS1. So more and more we do molecular profiling of the tumor to be able to individualize each treatment. At the same time, it's very important, of course, to know your patient. So what are the other medications, other diseases, and performance status, and all together you put the puzzle together to choose the right therapy in what we call precision medicine. So, and with more and more precision, hopefully, when new research is coming. So we know that the outcome, the survival of lung cancer, is very much dependent on stage. So with the early stages, stage 1, with the relatively good survival over time, this is months, 72 months. Whereas stage 4, the metastatic stage, has a much poorer outcome. So that's my rationale behind today's talk, to divide the research focus into different stages. So let's start with the early stage lung cancer. So it has been known for quite some time now, and this is still clinical routine, that if you have a stage 1B to 3A tumor after surgery, there is usually a benefit to treat with adjuvant or post-operative chemotherapy. And it's often a platinum-based treatment like cisplatin. And this is a meta-analysis, a pooled analysis that showed a benefit of just around 5%, 5.4% in survival at 5 years if you were treated with chemotherapy compared to non-chemotherapy. So this was really the basis for why we use this treatment. What is now happening as a research line, it's the focus on neoadjuvant treatment, so before surgery. So the idea and the benefit of that would be you may treat micrometastatic disease that you cannot see by eye or on an X-ray. And also, possibly more patients can complete the systemic treatment if you start with that. You can also have a readout, so when you do surgery, you get tumor material and you can actually recognize the effect of the treatment. Sometimes you want to downstage, you want to shrink the tumor to be able to operate. And it may also be that it's a good way to stimulate the immune system. So you get a better and a longer response with the T cells, for example, as well as the immunosuppressive effect that is known to be caused by surgery. So these are some advantages, and it's really much about immunotherapy in the neoadjuvant setting. So this is a comparison between monotherapies, only immune therapy, or chemotherapy together with the immune therapy. And there are different readouts here, but this is something called major pathological response. That means that you have very few remaining tumor cells surviving the treatment. And this is something that you can see in the resected material after surgery. And if you see here, if you use the combination IO plus chemotherapy, you double the response rate, you could say, compared to single immune therapy. So the idea now, and many studies are ongoing, is to combine immune therapy and chemotherapy before surgery. And a lot of studies are ongoing, so we will see you know the results coming up in the coming years. At the same time these studies are ongoing, there's a lot of focus on biomarkers that could potentially predict the response to immune treatment with these immune checkpoint inhibitors. And it could be in the tumor cells, so not only the well-known PD-L1 expression and tumor mutational burden, but also other immune pathways. It could be the tumor microenvironment, so the immune cells surrounding the tumor cells. There is also research ongoing to actually, if you take a blood sample and you could potentially detect immune cells and other circulating biomarkers that could tell you if immune therapy would be effective or not. Also, you will have the host or the patient's characteristics. That could be, for example, the gut flora. So you know about this theory that the bacteria in the intestine or in the gut could potentially play a role in the response to treatment with immune therapy. And also, of course, to be able to predict side effects, toxicity. So leaving immune therapy, another important research line is targeted therapy after surgery. And this was quite a recent published study looking at EGFR mutated non-small cell lung cancer, and in using osimertinib, which is a tyrosine kinase inhibitor of EGFR. And this study, the ODAURA study, was published quite recently, last year, and there was a clear benefit for osimertinib compared to just a placebo in disease-free survival. And this treatment has just recently received a positive opinion from the European Medical Agency. So I think this is probably a treatment that will come in clinical routine quite soon. There are also other targeted agents that are being studied in different clinical trials. This is one, the ALCHEMIST trial. This is a US trial looking at not only EGFR mutated, but also ALK rearranged tumors. And in this particular trial, you treat with crizotinib. So this is a way to have a backup for the surgery, really, and increase the response rate. So not to forget in early stage is radiotherapy. And for the smaller tumors below 5 centimeters or so, stereotactic body radiation is an established treatment as an alternative to surgery. And that could be in patients that are not so healthy in their lungs, the pulmonary function may be reduced, or there may be other reasons for not doing surgery, comorbidities, for example. But to know is that there is an interesting effect of radiation. It seems that radiation can actually stimulate and trigger the immune system. So if you irradiate, you upregulate immune factors that could be of benefit for immune therapy. And this is called the abscopal effect. And one such study we are doing actually in the Nordic countries, including in Sweden, where I work. So the patients receive stereotactic body radiotherapy and then are treated with immune therapy, a checkpoint inhibitor called durvalumab, so for up to 12 months afterwards, and with the idea to really get the synergy with the durvalumab and the radiotherapy. But there are several of these ongoing, so this is not the only one. So let's turn to locally advanced. And with that, you usually mean that you have a tumor in the lung, and then you have engaged lymph node metastasis between the lungs in the mediastinum. These patients are usually treated with chemotherapy and radiotherapy, and sometimes in combination. And this is a study called the Pacific study that has been published. So patients undergoing chemoradiotherapy afterwards received durvalumab or placebo, and for up to 12 months. And this is the result. This is overall survival. And there was a clear benefit for durvalumab treatment compared to the placebo. So this has now been introduced as a routine treatment in these patients. So what is happening now in research is to add the immune therapy during the radiotherapy. So not only after, but also during this. So this is one such trial that was presented at this year's World Conference for lung cancer in January. So patients received chemotherapy together with radiotherapy, but the new thing is the addition of pembrolizumab, which is immune therapy, as you probably know. Two different groups here, squamous and non-squamous, and the other non-squamous, so mainly adenocarcinomas. And this is a bit of a busy slide, but let's focus up here. So you can see here the response rate, overall response rate. So the fraction of patients that actually had this tumor shrinkage was almost 70%. Around 70%, so which is quite a good number, response to a treatment. So, and the side effects was, tolerable. It was not adding much more than the standard treatment. There are numerous of these studies ongoing with different immune checkpoint inhibitors. So this is just an example what is going on in research now. Similar to the early stage, also in locally advanced or stage 3, there is an effort to add targeted agents, targeted therapy, tyrosine kinase inhibitors after chemoradiotherapy. And this is a trial ongoing, the LAURA trial. It's a bit busy slide, but the idea is to show that patients are treated with chemoradiation, and then after this, they receive, half of the patients receive osimertinib and the other standard treatment. And then the results will be evaluated. And this study is ongoing, so we don't know yet the results. I should say that there are other trials upstarting and ongoing with other tyrosine kinase inhibitors like ALK and RET and MET. So this is also an intense research area. So let's go then to metastatic lung cancer, or stage 4, where a lot of research, as you know, are being done and have been done. And it's a lot of focus on these different molecular subgroups that I mentioned. So I try to understand how should these different mutations be treated in the best way. And we cannot go through all of them today, of course, but I have indicated with some arrows here 4 of the mutations that I will give as example. So one of them is HER2, that occurs in around 2 to 4% of non-small cell lung cancer advanced stage. And this has been a difficult target to treat, actually. But new drugs are coming out, new targeted agents, and this is from last year, and also with an update from this year from the World Conference. It's called trastuzumab deruxtecan. It's a antibody against HER2 and coupled to chemotherapy, a cytotoxic agent. So, and these patients had been treated before, so with standard treatment. And if they had a mutation in HER2 or a protein overexpression, they received this TDX agent. And the response rate here is around 60%. So the majority of the patients are responding. And each column here represents a patient. And when it goes down, that means that the tumor has some kind of shrinkage. So I think this is quite impressive data in patients that already received quite a lot of treatment. And this actually received the FDA breakthrough approval last year in May. So let's go to the EGFR then, or epidermal growth factor. So as you know, there are several of these tyrosine kinase inhibitors, first, second, and third generation. And you can use any of them. And these mutations, as you know, occur within the active site of the receptor and blocking the signal. So more and more, I would say, osimertinib is being used in the first line. It's not in all countries, not all centers, but more and more. And partly because of this trial, the FLORA trial. This was a trial where osimertinib was compared to standard EGFR TKI, mainly erlotinib or gefitinib. And for progression-free survival, there is a clear difference over time here. So this is the fraction of progression-free patients, and this is the time. And you see a clear separation. And it was also an important finding that also patients with CNS or brain metastasis had a similar good effect with this drug. So osimertinib has a good penetration to the brain, according to this. We did a small study. I could not refuse to show this from our own study to confirm these findings. So we for the first time, we labeled osimertinib with the radioligand, so you can actually detect it on a camera. It's a small radioactive molecule, and we could follow the uptake in the brain of osimertinib. And what we could see is there is this is from the start, and this is after 3 weeks. After 3 weeks, you have a good uptake and penetration to the brain. And this was 2 patients with brain metastases that responded very nicely only after 3 weeks of treatment. So sometimes the effect is really quick, and these patients also improved dramatically in their welfare and from the recovering from symptoms. One problem is resistance. There may be different kinds of resistance developing against these tyrosine kinase inhibitors. There may be mutations coming up in the actual target in for example, the EGFR. There may also be activation of what we call bypass signaling pathways, so other receptors, other signalers that bypasses the EGFR or the ALK. In some cases, there may also be a change in morphology. So you could go from a non-small cell cancer to a small cell cancer. So it's very important to try to get a new biopsy if you end up in that situation with resistance. So try to get some new material to try to pinpoint what is going on here. And nevertheless, even using the latest generation of EGFR TKI, osimertinib, resistance mechanism or resistance is a real problem, and there are different mechanisms for resistance. And this is quite a complicated slide, but it shows that in the different the pieces of the pie, there are different mechanisms for this resistance. It may be new EGFR mutations. It may be other factors that are upregulated, like HER2, MET. But also there is quite a large gray zone where we don't have the knowledge actually how to handle this, or what are the changes that you could target. So the research ongoing on this in this area is really to try to understand resistance mechanism, and which may be multiple. So one way to do this, as an example, is this Orchard trial. It's a platform study. So you take a new biopsy upon resistance, and then you do a molecular profiling, sequencing the DNA, measuring proteins, and according to the biomarker that you find, patients can go into different treatment arms. It could be with a MET inhibitor, savolitinib. It could be with the EGFR antibody, necitumumab. It could be immune therapy. And there are several of these studies ongoing, so this is just an example. Another research line is to try to handle the EGFR mutations that have been, that we know are hard to treat and that are very resistant already from the beginning. And one such group is the exon 20 insertions, which is around 10% of EGFR mutations. They are usually resistant to different EGFR tyrosine kinase inhibitors. But now new drugs are coming up that could actually have a good effect in these. One of them being amivantamab, which is an antibody binding to EGFR and MET. The other being mobocertinib, which is a small molecule that binds directly to the receptor. And I will just mention the amivantamab antibody. This was also presented on the World Conference this year in Singapore virtually. So patients had been treated with chemotherapy, platinum-based, and received amivantamab. And again, a busy slide, but let's focus on response rate. Around 40% of patients responded. And if you include the stable disease, so clinical benefit rate, you're up to actually 80% or 74%. So, which is quite promising from being a very hard to treat mutation with almost no responses. So studies are ongoing with this antibody. So let's turn to ALK then. So that's the other major genetic aberration that occurs in non-small cell lung cancer. Around 4 to 5% of adenocarcinomas. And you are probably familiar with the different ALK inhibitors that we have on the market and can use in the clinical routine. First generation, second generation, and now lately the third generation, lorlatinib. And the problem is that we don't know in detail how to use this, in which order, in which sequence, which is the best order. So this is something that we need to find out and do more research on. I will show you just a very recent study comparing lorlatinib with crizotinib. Again, progression-free survival. And you can see over time here that lorlatinib is quite superior to crizotinib. So this means that we have potentially yet another ALK tyrosine kinase inhibitor for first line. This has not been approved yet, so we are waiting for the EMA to decide on this. So nevertheless, which ALK TKI whatever ALK-TKI you choose. It's a good principle, again, to do a rebiopsy. If you end up in the resistance situation, there may be mutations in the ALK domain that is only sensitive to a few of these ALK inhibitors, like lorlatinib is the main effective treatment for this kind of mutation, the G1202. There may be other changes, a MET amplification. You can end up with a small cell transformation that you should treat in other ways. So this is also a matter of research focus. And one of the studies looking at this is the ALK master protocol. So in this, you take a biopsy, and depending on the marker you find, patients will be treated with different therapies. So I will also mention this very important signaling pathway or oncogenic driver, RAS or KRAS. It's the most commonly mutated target in non-small cell lung cancer, around 25%. And this has been a very hard to treat mutation with actually no drugs that could effectively inhibit these tumors. But recently, new, more selective KRAS inhibitors have been introduced, and one of them being sotorasib. This inhibits a certain KRAS mutation called G12C that occurs in around 13% of non-small cell lung cancer. So it's quite a large group, and in Europe quite similar to EGFR, the number of patients. So I will just show you that one clinical trial that has been presented also at this year's World Conference, a phase 2 trial, patients having been treated with chemotherapy, for example, before, and then receiving this sotorasib. And you can see that most patients respond in this waterfall plot. And response rates, or more deeper response, is almost 30%. But if you add the stable disease, you will have 80% that have kind of stabilization or shrinkage of the tumor. And recently, a phase 3 study on the same drug has been closed. It was comparing second-line docetaxel with sotorasib. So hopefully we'll see the results, within a year or something. So let's turn to immune therapy, which is the other cornerstone of our novel new treatments for lung cancer. So as you know, a very common biomarker that is measured in tumors in clinical routine is PD-L1. So if you have a PD-L1 expression, you tend to have a better chance or better response rate to immune therapy. And I've listed the most common ones down here. So I will just remind you about the routine treatments that we have now. So either you can treat with single immune therapy like pembrolizumab if you have a high PD-L1 expression in the tumor, 50% or more. So this was shown compared to chemotherapy to be superior. Also quite recently, or a couple of years ago, this study was published, chemotherapy plus immune therapy, in this case pembrolizumab. And it was shown that the combination with the immune therapy was better than the chemotherapy. And this was irrespective of PD-L1 expression. So here you have the PD-L1 negative patient, and you still see a separation in the survival curves here. And more lately, quite very recently published in this year, was this study having a combination immune therapy, nivolumab plus ipilimumab, combined with 2 cycles of chemotherapy at the start of treatment. And this also showed the benefit for the combination of immune therapy and chemotherapy. So this means we have now 3 different choices in first line. This has been approved now. And the 4th choice in first line really is this combination, nivolumab plus ipilimumab. So similar to the previous study, but no chemotherapy. And this has been studied in tumors that have a lot of mutations, a high tumor mutational burden. And compared to chemotherapy here, the combination was superior in progression-free survival. And this was irrespective of PD-L1 expression as well. So it's not easy now. We have 4 different choices, and it's not so easy to pick the right one for each individual patient. So this is where the research is ongoing now. You know, not only understand the PD-1 and tumor mutational burden, but also other factors. It could be in the microenvironment, so looking at immune cells. It could be the patient, the host, you know, what are the characteristics of the patient, and also the mutations. So we know that some mutation may actually give resistance to immune therapy, like this STK11 mutation. Upon resistance with immune therapy, there are also quite a number of studies ongoing to target this resistance, and this is one of them, the Hudson trial, European trial ongoing, and the patients go into different treatment arms depending on the biomarker. It could be a PARP inhibitor, a HER2 inhibitor, etc. So this is also a lot of research focus on this situation. So lastly, among the studies ongoing, we cannot, you know, omit to mention lung cancer screening. So I just have a couple of slides on this, but really to remind you, this is very important. So to increase survival for lung cancer, it's important that we are trying to detect these tumors at an early stage, as early as possible. And this is, as you know, there are 2 big studies, a US study and a European study, a smaller Italian study, showing at 5-year survival benefit, lung cancer specific survival benefit of at least 20%. So the research now is ongoing to improve that even more. So this was low dose computed tomography, so CT scans. So this study from Italy tried to add a biomarker called microRNA, which they are small molecules circulating in the blood. So you can take a blood sample, and if you had these present in the blood plus a change on the CT scan, you were much more likely to develop a lung cancer. So the development now is really to go from just detecting on radiology to add on these biomarkers, for example, blood samples, but also to analyze the pictures, the radiology in much more detail, called radiomics. And you can use artificial intelligence, for example, for this, machine learning. So some future perspectives the last few minutes. So what the research is ongoing now to try to understand not only the main oncogenic mutation, but also the co-mutations. Usually you have several mutations in a tumor. And what are the role of these? We know, for example, if you have a EGFR mutation and the mutation in TP53 or P53, you risk to have a worse prognosis. So this could have an impact on the behavior and the treatment of these tumors. The design of clinical studies, so instead of looking at one target at a time, you can do these called umbrella trials, where you look at several targets at the same time. one tumor type. You can have basket trials. Then you look at several tumors at one time and several targets. And some of these are listed here. This is a couple of examples of these studies, one being the LungMap trial for lung cancer. According to the biomarker testing, patients go into different treatment arms. At Karolinska and at 7 other European centers within Cancer Core Europe, we have also a basket trial doing the same thing. We need cancer registers to collect clinical data. So we know that unfortunately, less than 10% of patients go into clinical studies. So that means when treatments are approved, we actually don't know so much about these treatments. And in some cases, treatments are also rapidly improved. It's going faster and faster. So we need to learn, in the real world, in real clinical practice, more about these treatments. And the best way, I think, to do that is collect the data in different registers. And these are some examples of such registers. For immune therapy, we need to learn how to combine, in an optimal way, different treatments, immune therapy together with chemotherapy, radiotherapy, blood vessel inhibition, anti-angiogenesis, and other targeted therapies. And in which sequence, which should you start with, or should you use the combination? So a problem we have is heterogeneity. So the tumor may look different in different parts. So if you take a sample in this blue part, it may not reflect the whole tumor, the characteristics of the whole tumor. One way to do this, and it's also a lot of research on this, are the cold liquid biopsies. So you take, usually it's a blood sample, and you can actually detect circulating DNA in the blood. And it's believed that this really could reflect the whole tumor burden in the body by just taking one sample. And of course, it's easier for the patient, non-invasive, easily accessible. And it's then more easy to follow during treatment and monitoring. So in the end, the picture is really complex. You need to get a lot of information about the tumor, of course, about the patient as well, with more and more advanced techniques, including imaging that I didn't mention so much today. So in the end, we really aim at doing precision cancer medicine with higher and higher precision. And this is a lot of research that is needed to achieve that. But I think I'm optimistic and that we have really achieved a lot, and there is a rapid progress. I'm optimistic for the future and for all the patients. So thank you very much for your kind attention. I used 3 more minutes than I should. I'm sorry for that.
No, that's absolutely great. And thank you so much, Professor Ekman, for this very comprehensive review of all the things that are ongoing. And also I would like to recap this last message of hope and see how things are rapidly progressing in terms of treating this disease. So we have like around 15 minutes for the Q&A session. I have received some questions in writing by some of you. I would just like to remind you that you can still send your questions in writing through the chat or the Q&A window, or if you prefer to do your question by using your microphone, just press the raise hand icon in the panel of the application and I will unmute your microphone. So being said that, I'm gonna start with the first question, which says, when it is about immunotherapy, I see lots of different options like pembrolizumab or durvalumab. I read all them are anti-PD-1 or anti-PD-L1 drugs, but is there any substantial difference between them, or can they be used alternatively?
Yes, yeah, it's a very good question. Thank you. And this is something that has been studied because, one is really blocking on the tumor cell, the other is blocking on the T cell, the immune cell. So the receptor, the PD-1 inhibitor will block on the immune cell. So far we haven't seen any difference. So we really use them interchangeably. So it's not any obvious differences, and theoretically also they should work in the same way. So this is what we know so far.
Good. The next question it's about TKI treatments. So this person says, so as in other diseases like chronic myeloid leukemia, is there any ongoing study on stopping TKI treatment in patients with a complete response, or we are still far away from that?
Yes, it's also a very interesting question. Thank you, because we do have patients that achieve a complete response, so you cannot see any sign of tumor, and then it could be long treatment times, and you do your radiology and you don't see anything, and you ask yourself, okay, can we stop here? So far we don't have data to support a stopping of treatment. There is a fear so far, and there are reports on this, and we see it sometimes, that if you stop a treatment, there may be a flare, so the tumor gets much more active again, and could happen quite rapidly. And that's why it's a bit difficult situation to do these studies, and maybe riskful, but I think that, and hopefully we can come to that day when maybe a tyrosine kinase inhibitor in combination with, for example, radiotherapy or surgery, you actually remove the last parts of the tumor, and that this in the end may be a cure, or for sure a chronic situation. But there are no such studies at the moment because of the reason I mentioned.
Good, thanks, Professor. So next question is about radiotherapy, and says which patients, or which subtype of patients are eligible for SBRT as an adjuvant treatment option?
Yes. So exactly. So if the question is in the adjuvant setting, so first of all, SBRT traditionally, stereotactic radiation is used as an alternative to surgery for the reasons we discussed. I mentioned it could be that you are medically inoperable, or some reason not being eligible for surgery. So then we have very good results with SBRT. It's comparable to surgery. And we have some criteria, to look at when you select for radiotherapy. It should not be a too large tumor and not too central. So for the adjuvant setting, so meaning could be in after surgery as a complement to do a surgery first, that would mean that you would have a remaining tumor somewhere. And I'm not aware of such studies for SBRT. That it's not a routine that we use so often. But theoretically, if you have a small remaining tumor, it could actually be an option. So I don't see why not. More commonly, we use sometimes more conventional radiotherapy. If you have microscopic disease that you detect after surgery or at the point of surgery, you may need to irradiate afterwards with more conventional. But again, stereotactic could be with more precision if you have such a remaining tumor.
Great, thank you. We still have 4 questions left, but if I have time, there will be an additional one. So the next one says, is CAR T-cell gene therapy a potential option for treating lung cancer in the future?
Yes, very all good questions, including this one.
We have a good audience.
It's very interesting. As you know, CAR T-cell therapy has been very promising and now in clinical routine for some hematological malignancies. So, and there are studies ongoing on lung cancer as well. The problem, I think it's a promising field, and I really hope it will become reality for treatment in clinical routine in the future. But before that, there are some problems that needs to be solved. So when you do a CAR T-cell therapy, you need something that is unique for the tumor. So, and that may be a problem that, targets proteins that we treat are also present in the rest of the body. So I think the risk is the side effects that you have, reactions outside the tumor. So I think that needs to be studied carefully, and there are a few of these studies starting and ongoing. So I'm hopeful, but a bit, waiting for these results.
Great. Thanks. So, well, there are many messages thanking you for the very clear and good presentation. So I would like to pass them to you as well. And the next question is around small cell lung cancer, and it is: are there any relevant updates on research when it comes to a small cell lung cancer?
Yeah. That's, again, a great question. And I was sorry to have to omit that today, because of time constraints. And also for the reason is that, there are some progress, but unfortunately, too few, I would say, as we have seen in, the recent years, there is not so much progress for small cell. But I, with that one exception, I would say, I think the addition of immune therapies is very promising. And there are 2 large phase 3 trials in first line advanced small cell lung cancer, one with atezolizumab, one with durvalumab in combination with chemotherapy. And there is a benefit, significant difference, if you look at the whole group of patients. This has not been regarded as, enough effect on the population level to be approved by, unfortunately, in some countries, including in Sweden, where I work. So I think the problem here, or the challenge, is to find the right patients. So there are clearly patients that benefit from this, but who are they? So immune therapy, I think we should work more on with biomarkers. There is also some chemotherapy like lurbinectedin that is really showing promise in second line and later. Topotecan has been the main choice for many years, and now there are new chemotherapies like lurbinectedin that shows good results. So, and I know also that there are these antibody drug conjugates that show promise. You couple a chemotherapy to an antibody, and there is research ongoing on this. So I think we can be more hopeful than we have been for many years, actually. But there was not so much new and strong data that I could show today, but very important.
Let's cross fingers and hope that in the future these patients could really take benefit on this. So a couple more questions, and I think we will be making it on time. So the next one says, regardless the current benefit evidence on studies regarding low dose CT screening in high risk population, can you see a real systematic implementation of screening programs in the clinical practice around Europe?
Yes, I certainly hope so. I know that, we have two large studies, the Nelson and the US study showing, similar results. I think there is no question that, there is a benefit. And I think the problem is for each country to find their own way. I speak for myself in Sweden. We have our health system, and we need to, organize and how to identify these patients, and how do you follow these patients, and most of the patients will not have a lung cancer, but you still need to investigate the nodules that are benign. So I think each country should find their own solution, but I think it's important that we help each other and try to align within the European community, because we can learn a lot from each other, and it's a good driving force to implement, something that we should do. So I really hope it, and I think it's realistic, yes, in the coming years. Yeah.
Good. So I think we have time for this last question before we end up the session. Who says that seeing that survivorship in patients with oncogene-driven mutation have increased during the last few years, have you seen an increasing number of trials which highlights the importance of including patient-reported outcomes or quality of life markers in their designs?
Yeah. Again, great question. I'm totally with you. Thank you. I think this is very important, and it's increasingly, there is an increasing awareness about this, and also in the ESMO community, about this magnitude of clinical benefit scale, where actually quality of life is ranked, and you get points for a certain treatment depending on the quality of life. So if you can achieve better quality of life and less symptoms, these drugs are ranked higher. But in the end, that's one side of it. But the other is, of course, what it means for the patient. So we, taking a medication each day, day after day, for a long time, then even milder symptoms can be really, burdensome. So I think it's really important to have this in parallel to the, the survival analysis. And I think more and more pressure is put on this. What I see, however, is that usually these data are presented, at another later conference, maybe 1 year after, half a year. And I think that it should be presented at the same time.
Great. So I think, we are almost about running out of time. So that was the last question. And before closing, Professor Ekman or Simon, you asked me for forgive you about the politeness.
Yes, you can call me Simon.
I would really like to thank you so much for this presentation, for your valuable time today. I think it was very challenging to compress all these updates and information in such a short a range of time, but I think you did it great, and I am seeing a lot of messages thanking you for the presentation. So our attendees have really enjoyed. So thank you so much for your time today. And and I would also like to thank you all you for attending this webinar. And I would like to remind you that the full content of this session has been recorded and will be soon uploaded to our YouTube channel, so you will be able to see it again. And also, before closing, I would also like to encourage you to follow up our activities, next webinars, projects in our website, which is www.lungcancereurope.eu, as well as to follow us on our social media channels, mainly Facebook and Twitter. With that being said, I really wish you a very fruitful evening, and I really look forward to meeting you all shortly in our upcoming webinar. So thank you so much. Thank you again, Professor Ekman, and I wish you a great evening. See you soon.
Thank you. Thanks, Stefan.
Thanks.
Bye-bye. Bye.